Neurogenic bowel management in adult spinal cord injury. I think it's relatively similar to the pediatric spinal cord injury, but I don't know because I don't play with them, but it's pretty similar. All right. And see that's to keep you awake. If you didn't notice that zap going by, if you miss it, it'll keep you awake. See? All right. So we're going to start out with definitions, look at epidemiology, the anatomy, etc. Then, kind of the mechanisms of all this working. And then we're going to talk about how we manage it with diet and medications and things like that. And then bad things that can happen. I don't have any gruesome pictures, I don't think, because I don't like gruesome pictures, but we'll talk about it later. All right, the definition. Whoa. All right. Dysfunctions following spinal cord injury resulting from in changes of bowel motility, sphincter control, and gross motor dexterity, which all interact to make an impact on your lifestyle and limit your quality of life. That's why it's such a big deal. It's like one of those, it's number one and number two, bowel and bladder, and maybe in the opposite order. Because bladder happens more often, we call that number one, and because neurogenic bowel happens a little less frequently, we call that number two. But if you had to ask which one was more devastating to have an accident, I think most people would say bowel because it's really pretty bad. Anyway. All right. So, all right. New SCI, approximately 10,000 a year. So I don't think that number's changed a whole lot. In fact, it may have gone down slightly because I know that traumas from car wrecks and stuff like not as common to have spinal cord injury anymore as it used to be back in the days. But activities and lifestyle are affected. And
this is Brian. I just told them 17,000, and I've seen 12,000 elsewhere, but it's around that ballpark. But nothing's official.
You know what I mean? There's no good study anymore. I mean, the model center doesn't capture enough of the whole population to really extrapolate as well as you'd like to. Anyway, bowel dysfunction, 40 to 60% of people affect life activities and lifestyles. I've seen people that literally did not leave the four walls of their house for years because their bowels, they were always worried about having an accident or not being able to take care of it if they did. And that's really horrible to me. They seem to make it. They say, yeah, that's the way it is. I find it hard to support that. Let's say it that way. A third of people with SCI had worse bowel function. They had alterations and changes that made it not as good 5 years post-injury. So it does change over time, and I think that's really important to kind of realize that it's not a static thing. Quality of life and up to 62% of spinal cord injuries, I'd say that's reasonable. And then the occurrence of uncontrolled bowel evacuation, source of greatest social discomfort. And I think that's hard to imagine, or it's not hard to imagine if you kind of put yourself in that situation, but it's hard to imagine if you think, being in a chair or being, having to use other things wouldn't be a little more socially uncomfortable. But that being said, I think most people are more comfortable with somebody in a chair than they would be with them being soiled in a chair, if you know what I mean. So I don't think it's too hard to kind of appreciate overall. All right. This is the really cool stuff, because this is the stuff that you learned in 6th grade, and that makes it really cool. 4th grade maybe. So we've got the esophagus, the oropharynx. Let's not leave that one out. Going into the esophagus, stomach, the small intestines, the colon, rectum, and anal canal. This is all known. Your associated glands, and then mechanical and chemical digestion starts up in the mouth, digesting, chopping it up, making salivary enzymes start the process, make it slippery, let it go down the esophagus, and then it comes on down. We'll talk about later. But the bottom line is the digestive end product is absorbed in the small intestine. Most of the nutrients are out by then, and the proximal colon has more of the water and some vitamins and recycling of bowel salts and things like that. By the time it's in the distal colon, it's pretty much leftovers and ready to be processed for delivery. So the colon's about 5 foot long. It's closed. It's bounded by the ileocecal valve and the anal sphincter. These are no big shakes. You guys went to anatomy class a long time ago. And it's smooth muscle, both circumferentially and longitudinally oriented. And the key, though, is that the absorption of water and electrolytes from the chyme that's up, and then the storage of fecal matter. The proximal half, absorption, and the distal half is storage. So really, that's absolutely reasonable. In fact, most stool is storage, and a lot of it is dead bacteria from the gut itself. So it supports the growth of and the maturation and all those different things in the beneficial bacteria that live there. We obviously have to do something about it when it gets out of hand, like C. diff and things like that, overgrowth. But that's a whole nother story. All right. It also, the bowel itself secretes mucus to make sure that the stool is lubricated and slides through better. And then it allows it to push through the rectum and into the anus and out the bottom, or wherever it happens to be. That point. All right. The rectum is formed where the smooth muscles thicken, and they form that internal anal sphincter, which is up in there. Internal anal sphincter. External anal sphincter is a circular band of striated muscle, and then the colon and pelvic floor musculature receive the parasympathetic, sympathetic, and somatic nerve supply to make it all. So sensation and volitional squeeze, as well as unconscious storage, and then pooping, because sympathetic stores, parasympathetic poops, right? All right. So in the mucosa of the colon, the epithelial is in the lamina propria is rich in collagen and elastin, so it allows the stretching and the contracting, etc. And then the muscularis mucosa is the thin layer of intestinal smooth muscle. That's all in the bottom, right as the working inside. The submucosa is a Meissner's plexus. And that has, again, the connective tissue and all that stuff there, and then the dense circular layer, and then the Auerbach's, the myenteric plexus, is outer part, and that's a longitudinal layer. So if you think of the Meissner's, is the stuff that mashes stuff up, so it squeezes circumferentially, and then the Auerbach's is the stuff that propels. It's longitudinal, so it makes things push down the stream. So that's the take home on that one. So Meissner's inside but squeezes, and the Auerbach's is on the outside and propels. And that's the way I would think about it if I were you. It's easy enough on that one. All right. And we've got all these silly things that feed into with the sympathetic and parasympathetic nervous systems. And if you notice all these little connections to the stomach and the liver and the controls of the adrenal glands and everything else, and just about all these interconnections, you know it works. Like I said, peeing, sympathetic stores, parasympathetic poops. So it's the way to think about it. So parasympathetic supply, don't forget the cranial nerves, the vagus nerve goes, and that's to about, if I remember correctly, it handles the first 1/3 of the gut, if I'm not mistaken, right down to the, just after the small intestine, or right at the first third of the small intestine, if I'm not sure. Let's see. It'll say up to the transverse colon. There you go. How's that? I knew I had it in there somewhere, right? So it starts in the medulla and then controls the thoracic and abdominal viscera up to the transverse colon. So that's a pretty good part of the nervous system, if you think about it, pretty good part of the colon too, where the pelvic splanchnics come out of this S234, and that forms the nerve irrigantes to control the colon and rectum, and that stimulates both the secretory and the motor propelling. So parasympathetic is pooping, and so it will cause those propelling waves to be stimulated. Sympathetic. Now, it's just like all the sympathetics. There are preganglionic fibers in the intermedial lateral columns, And we know that there's the paravertebral sympathetic ganglion, and then there's the celiac and inferior mesenteric ganglion as well, and the thoracic spine. The paravertebrals, then those are where the let me think. That's where the ganglion, right? Anyway, that the small muscles of the head and neck with secretory elements, and then the middle cervical stellate with the esophagus. And there's 12 pairs in the somatic stomach and small intestine, thoracic pairs, and 4 pairs of the lumbar that come out. I don't think anybody's ever going to test you on how many pairs come from where, anything else like that. But it's important to know that it helps to store and helps in the secretory elements especially. Did that change? Yep. All right, so we're also controlling the stomach, gallbladder, etc., with the sympathetics, and then the colon with the inferior mesenteric, and that provides for relaxation and storage, and then contraction of the anal sphincters. And why do I say fight in there? Well, sympathetic is like fight or flight type stuff, right? Well, when you're flying, when you're trying to get away from the saber-toothed tiger, you don't want to leave an ink jet. We're not a squid or anything like that. So you want to not poop during that time. You don't want to poop your pants, So keep it closed and run fast. And I think that's the key. It's relaxing it and let it hold on to it so you can get out of there faster. So next time you find a saber-toothed tiger, let me know if it works, okay? All right. The enteric nervous system, we talked a little bit about it. There's the Meissner's and Auerbach's plexus, and that has interneurons up and down the gut. There's actually more nerve cells in the GI tract than the entire CNS. If you look at actual mileage and numbers of neurons and that sort of thing. So it is a very complicated system, which we know only a small amount about, I think, in terms of the interconnections and feedbacks and all these other things that happen. And that's why that enteric nervous system can function without an extrinsic control. That's why it continues to work despite the CNS being completely dislocated or disconnected, if that were actually possible. If you took somebody and meat cleavered their cord, you would think that the whole of the nervous system would be disconnected, and by and large the big majority would be, but then there would still be the autonomic systems that might get through and some of those other pathways. So but still it's pretty automatically controlled. It coordinates and directs that intrinsic motor and secretory action. And like I said, over 100 meters of neuron. It's way more than the spinal cord and the CNS. There are pacemaker cells within the gut. And that's why we always say everyone has their own kind of rhythm. Everyone does have their own kind of rhythm. It's both circadian and time related as well. Because these pacemaker cells, everyone has a normal for them. And that's why you always, in part of your history, ask, what's your normal? Because you're not going to make those pacemaker cells do something significantly different from what they always used to do. So you work with them, not against them. Sorry about that, but I'm going to turn my phone off. Anyway, again, peristalsis occurs at different rates along the GI tract because there's some, you need more activity up high where you're actually churning things around and trying to get the nutrients absorbed and exposed to the villi and all that stuff. And then a little bit lower, it doesn't want to peristalse because it's storing until it's ready to move along. So it's not as much squeezing and stuff down low. That's all right. All right. So the somatic nervous system, it obviously handles a volitional motor function and some sense organs like the skin and stuff like that. And the pertinent part is the external anal sphincter, which has the pudendal nerves, and that helps to achieve volitional continence. Let's say it that way. So it also allows you to sense that things are there. And if you really have good discrimination, it'll sense whether it's liquid or solid or gas. And that is a very nice thing to have. If you don't, which most of the spinal cord injuries don't, it makes for a little less automatic system. In fact, a lot less automatic. All right, so myogenic activity, that's the localized mixing, agitates those contents, helps the nutrients coming out. And then the peristaltic activity, that Auerbach's plexus, propels that bolus towards the rectum. My consideration is that peristaltic activity, especially for propelling, works better when it's actually got some substance to work on. I didn't say rocks, I didn't say really hard, I said substance. So not goo, not slush. If you think of toothpaste, it's hard to make it squeeze if you don't squeeze it the right. But if you squeeze the toothpaste in the middle, it's not as efficient as if you squeeze in the end. Or if you think even more like a golf ball in a garden hose, if you wanted to kind of get it squeezed out, you'd have to grab behind it and squeeze it down. But if you had really squishy garbage ball in a garden hose, you never get it out. You'd never be able to get behind it and push it. So you need some substance. So that's my supporting plea to give them fiber. Anyway, all right, so there's tons of chemical controls. We don't even know half of them or how they all, or I don't, let's put it that way. I'm sure there's somebody out there that knows that substance P always does this and gastrin makes this happen, and I can't keep up with it. It's way too complicated because it could happen to that it works in this area this way, and later on down the road it works in a different area a different way. So the bottom line is there's a whole lot of chemicals, including stretch receptors providing substance P, which will then make the gastric, so we'll talk about that later, but it'll make the gastric stretch cause more colonic motility. And it's usually these kind of little chemical contraction or chemical controls that it enhance that. And then obviously the nerves, we're going to talk about that with the enteric reflexes. All right, these are two really essential ones. In fact, three of them actually. The two top ones are the ones we utilize more because the recto-anal reflex is inhibitory. And basically that one's not as helpful in terms of spinal cord injury. But the top one, that gastrocolic reflexes, it's peptides from the stomach, I believe it's substance P. The stretch of the gut says, hey, Charlie, there's a big load coming. Why don't you make some room? And so Charlie in the gut sends a message via chemical down to the guy in the rectum or the colon and says, hey, I need a little room. I got a big load coming, a big shipment. And so about 30 to 60 minutes after meal, that's going to be increased. And it's going to keep that propelling. Those longitudinal fibers are going to propel all the way down, make some more room and go, okay, go ahead and send it on through. And it's going to facilitate emptying of the gut as well, out of the stomach up high. The rectocolic reflex is obviously when a lot of that waste material hits the distal bowel, it'll stretch that area, and it tells the proximal bowel, there's another, they pick up the line down there in the receiving department and say, hey, you want to empty all of it out yet? And if you either reflexively, it will start to contract and propel those the rest of the proximal bowel down to eliminate completely as much as possible during the time of evacuation. The recto-anal reflex is an inhibitory reflex, and that relaxes the inhibitory anal, the internal anal sphincter if you have increased colonic pressure. Again, that's allows the reflexive relaxation, so it can pass once it comes on through if there's increased colonic pressure. So we don't really facilitate that as much. These other two we facilitate and try to utilize more. these are, I've never really, this inhibitory up on this side, on the red side over on the left-hand side of that picture. There's some ways that things are working to inhibit and via different, there's gastrocolic, gastroileal, gastrointestinal, you know, etc. So those are excitatory, obviously. All right. Continence and defecation. Okay. Continence. It's maintained by that closed internal anal sphincter and by the acute angle here of the anorectal canal, which is the pubic rectalis pulls and keeps that tight. I guess that's the best. It keeps the angle in there. Now, when you're actually voiding or passing, is I guess that's voiding. It's not voiding. It's a little. Anyway, you're having a bowel movement. That sling relaxes and it straightens out that angle and allows things to pass more freely. The key with that is sitting an upright posture facilitates that, or I guess crouching also gets you in the right angle, because a lot of cultures don't necessarily sit, but it works and it gets it all aligned and where you need it to be. All right, so sympathetics L1-2 go via the colonic nerve and increase that tone. So this is keeping that internal anal sphincter here and the pupil. And then when rectal dilatation, so when that rectum gets full, that tone is inhibited and causes it to become relaxed. Digital stimulation is how we fake it, or at least trigger that relaxation as well. So we're making use of that colonic reflex, or the sphincter reflex anyway. All right, so neurologically intact stool pushes into the rectum by peristalsis, clearly, stretches that puborectalis and the rectal wall, and sends that urge to defecate up high into the brain. And brain can obviously override some of this, because if you really got to go but don't have time, you can suppress it to some degree. Stool would then be retained by voluntary contraction of that external sphincter. You're holding on, right? Everybody's probably experienced that more than once. Anyway, then if you're in a place that says go ahead, you sit down, that volitional relaxation of the external anal sphincter and the puborectalis straightens and relaxes and allows that angle to relax and allows the stool to pass. And then it's pushed on down with a combination of peristalsis and increased abdominal pressure via its valsalva. Now, unfortunately, we'll talk about the lack of potential valsalva and some of the other things that make this a little more complicated with spinal cords. All right, 2 patterns of dysfunction. Above the conus medullaris, so this is the normal, I want to call it normal, upper motor neuron spinal cord injury. That's one pattern. The second pattern is below the conus medullaris, and you have flaccid bowel and flaccid lower extremities. So one is considered a spastic or potential for spasms, the more normal pattern of spinal cord injury, and then also stroke of the cord, or vascular insult to the spinal cord would cause that. Where below it's flaccid, and that's the only one that's definitely significantly different. It's also kind of hard to detect or determine initially. It takes a little while to kind of declare itself. Upper motor neuron spinal cord injury results in loss of conscious external anal sphincter control and sphincter relaxation at all. Loss of rectal sensation, so you can't feel like touch, pinprick, etc. You can't discern whether it's gas, whether it's solid, if anything's there at all. And then you could also have decreased ability to increase that inner abdominal pressure, which keeps your valsalva low. So that's all the things that upper motor neuron has going against it, or you have to work with. All right. So upper motor neuron is what we're going to talk about first, because this is the normal for spinal cord injury. I'll say it that way. It's more common by far. I think caudal injuries are in the 5 to 10% range, maybe, of all. I'm not sure of that number, but it's definitely on the lower end of the spectrum. I don't think it's any higher than that at all. All right, upper motor neuron. You have a spastic external anal sphincter, and it requires defecation to be anticipated in order to have it work well. Reflex defecation is initiated by stimulation of the finger with fingers, or artificially with ditch sticks or things like assisted devices, if necessary. And then a suppository, usually we start with those. There are many people that do not maintain suppository use over their lifetime. They'll get to be pretty facile with just digital stimulation, and that will be sufficient to make this all trigger and work. That would be ideal for everyone. Some people continue to use suppositories. It's okay if you do. Either way works. It just becomes less to deal with if you don't need to. All right, the stimulation activates that rectoanal inhibitory reflex, and we get more propelling and relaxation, and everything comes on down. So it's ringing the doorbell and seeing who answers the door as it comes on down. So that's pretty much what we're working on. A lower motor neuron, this is the smaller number and the lower flaccid type things. They're complete or partial injuries in the caudoclina. It results in flaccid pelvic muscles, which over time can cause big problems. You can actually get prolapses much more easily with these guys, especially. And then no reflex response to increased abdominal pressure. So even if you push, you don't get that increased propulsive activity. And then you have an external anal sphincter that's lax and relaxes, and basically you get fecal incontinence. So the key is to modify the character of the stool itself so it isn't coming on down as liquid or as loose. All right. So on the lower motor neuron, you have loss of parasympathetic control and reflex to the internal anal sphincter, so you have less anal tone, and you have no external anal tone, and you also reflex peristalsis. We already talked about that. All right, we'll keep going here. Sorry. So when you're talking to someone trying to assess their bowel function, you need to know their premorbid function and medical condition. Again, like we talked about before, that premorbid, how often did you go? I go, I don't go, but once every 3 days. Well, that's fair. That's normal. Don't be embarrassed. It's normal for you. I go after every meal. Yeah, okay, that's fair too. Those are ends of the spectrum that are reasonable, and not everybody's they're gonna fall somewhere in the middle of that. If you're outside of that, I would suspect a little more pathology premorbidly, and that may be a concern as well. What is the current bowel program? How do you do it now if you're talking to someone that's been a spinal cord injured person for a while, or had that problem for a long time, and or if someone's brand new, how's it going right this minute? Because you got to know where you're starting. I haven't gone since I got injured, now it was 2 weeks ago. Okay, let's talk, and then we'll get to work. And patient satisfaction, obviously. Yeah, I only go every week. Are you satisfied with that? Well, I don't have time to do it. Well, I'm not satisfied with that because I'm worried about you damaging yourself. Can we find another way to make that happen more than once a week? All right, so current symptoms. Are they distended? Because distension can cause respiratory compromise, can cause early satiety, nausea. So those are things that said, hey, you're bound up and it's getting in the way. We've actually had people that were distended and they didn't have their bowel programs that actually came off a ventilator after they got their bowels moving, which is hard to imagine, but it's true. What difficulty are you having in unplanned accidents, bleeding, etc.? All of these things. What are your symptoms? It's good to know. And then how do you do it? What's your procedure? What are you doing right now? How long does it take? And what's your stool like? Is it soft formed? Is it hard? Is it loose and gooey? You know, all those things. And what do you take to get it? All these things are good history for a neurogenic bowel. And with the physical exam, do an abdominal assessment, make sure they're not filled. Some people can actually feel like, some people think, and I've never deluded myself to think that I could figure out if they're full and where it was and stuff like that. I can't. I guess people that are really good at it and take the time to do it really well probably could get some sense of that. I've just never been able to get that. A rectal exam is a good part to do because now you'll get the idea of whether they have that tone. You'll also see if they have hemorrhoids or prolapse and things like that that are going to be a piece of the puzzle that you need to take into consideration. And then see if the anocutaneous and the bulbar cavernosus reflexes are there. That what you're doing then is trying to determine upper motor neuron versus lower motor neuron. It's very tough if you saw a person come in on a stretcher from their accident and you didn't get a bulbar cavernosus or anocutaneous reflex. That doesn't mean they're lower motor neuron, because it could be that they're in spinal shock. The key, though, is most of those reflexes, in fact, both of those reflexes should recover in somewhere between 48 and 72 hours, sometimes a little bit longer, but very rarely past 3 or 4 days. Just is going to be there, or they probably do have a lower motor. Look at your clinical picture, though. If, you know, they're doing sit-ups in the bed, it's probably not upper motor neuron anyway. Management of neurogenic bowel. Okay. An assessment of knowledge, cognition, function, performance, etc. You need to know what they can do and how much caregiving they have available or how much they need. And so that's really important. So this is an assessment of function. Is how disabled are they with regards to their bowels? Sitting tolerance and angle is going to be a big deal. They're laying in bed only. They can't sit up. Well, why not? Is it skin? Is it, what is it? Sitting balance. Do you need a chair, a commode chair that has side supports or something to keep them from falling out of the chair, essentially? How much upper extremity strength, and do they know where their hands are and proprioceptively? Can they get a sense of their fingertip position to help themselves to perform this activity? Hand and arm function. Spasms, that's a tough one, because if you're spasm, it's hard to get a hold. It's even worse with cathing, but it's definitely playing a role in the bowel program as well. Transfer skills. Can you get on and off the commode? How do you do that? Do you need a Hoyer lift, etc.? What are your skin care risks? Are you sliding across and ripping the hole in your skin? How long are you up there doing this program? I've had people that actually got really bad decubitus because they were on the commode for an hour, 2 hours at the time, and it was a hard commode, and they didn't think that was a problem because it didn't hurt, and it just over time they got a big decubitus. I've also seen people with try and use bedpans, and that's really horrible, because if they got left on them, that can cause big problems as well with pressure sores. Home accessibility. Can you get in and out of the bathroom where it's normal to go, or do you need alternative equipment to do it other than in the bathroom? And then how cognitively can they direct others? And I think that's another one. Depending on your population that you're working with, it's a significant issue, and it all plays a role. So you design a bowel program to provide predictable, effective elimination and reduce problems in GI complaints. It's obvious. And you want to take into account personal goals, the availability of attendant care, or the need for attendant care at all, and then their life schedule. I just can't get in there more than once a week. Well, you need to figure out how to make time for this because it's a problem. And then the quality of life as well. So we talk about bowel program initiated during that acute care and then revised throughout the continuum of care. So we're talking until they're dead. They need to, you talk about it, you ask. When they come in, how's your bowel program? Doing great. How long does it take? How often are you going? Do you need help? How's that going? Do you have enough help? And, do you need refills on that? Because it's working great. So establishing that bowel program on reflexive bowel, it's a chemical stimulant to the rectal mucosa that stimulates that rectocolic reflex, and then you have to wait at an appropriate time, which is about, it depends on which chemical stimulus you use. If you're using a magic bullet or some of the others like mini fleets or the, what's it called? The little mini enemas, one of those, that's a direct chemical stimulant that's there within 5 minutes, and it should be taking effect within 5 to 10 minutes. If it's a regular Dulcolax suppository that melts a little slower, that may take 20 minutes to just get that stimulant up against the rectal mucosa and start the process. So it may take a little more. We try to get people in upright positions, but side lying with left side down, so you have gravity of the colon at least helping you out. And then perform digital stimulation and or manual evacuation, and then continue the stimulation until evacuation occurs. So once you've got it established, you can modify it based on frequency, potency of the stimulant. Maybe you don't need to have a full Dulcolax. Maybe you could use a glycerin suppository or something like that, or just DigStim alone potentially. And then stool consistency with, you want it soft in form, that's readily moved, and with that rectal stimulation. You want enough that you can get on one end and push it all the way down with that peristalsis, so it doesn't get gushed back and forth. All right. Now, this is the other side. This is that areflexic, that lower motor neuron bowel. Again, you're going to try to get upright or side lying, and you're going to try to push with your stomach muscles, because these guys are injured much lower, L2, L3, much lower down. So they're going to have a lot of their abdominal muscles working for them, so they can push pretty well. Now, you don't want them to push their eyeballs out, and you don't want them to have, retinal hemorrhages because they've been pushing so hard, because they will have a lot more problems if they push that hard. The first part goes, get the stool confirmed, formed stool that can be retained so it doesn't leak. And then technically it's not exactly the most palatable thing to talk about, but you want it firm enough that you can get a finger in the stool and pull and get it to come down. You actually extract it. So it's manual evacuation along with that Valsalva to try to get it going down. A lot of times they talk about emptying the bladder so you're not pushing so far, so you don't get that vesico-urethral reflux. You don't push the bladder up into the kidneys and stuff. So I don't know that that's always talked about so much, but a lot of these guys will avoid when they're pushing, because that's a part of the process as well. That increased Valsalva is going to push out as well. So this is the old, everybody remember this one? Sorry. That was the old pyramid. It's probably not even the same anymore. I can't even remember if they even talk about it, but you know, you got your oils and good stuff up there, the stuff that tastes good, and then you got the pretty good stuff that binds you, and then good proteins and your vegetables, which are really important because that's going to be your fiber group down here pretty much, and then your breads and stuff that everybody enjoys as well. But foods that decrease bowel transit time are encouraged. So fiber decreases, and the increase, it makes that soft, bulky stuff. That's why I'm a real fan of additional fiber to help form the stool so it's more manageable and more propelling in character. A 15-gram dietary fiber is ideal, probably even more than that if you can get it. But in our society, it's harder to come by this because it's a lot of it's processed out, unfortunately. But this, I would strongly suggest trying to get it the natural way, as in, you know, good foods and healthy foods that you're buying at the store and eating. But if not, supplementing is important, and we'll talk about that. All right. Adequate intake of water is also, or fluid, period. About 64 ounces a day, 2,500 to 3,000 cc's. But again, that's to balance it with the bladder program so that you're not overdoing that as well. So it is a push-pull kind of thing, if you will, because you have to get enough that your bladders work, or that your bowel works, but not so much that you're in the toilet all the time trying to cath or leaking or overflowing and that sort of thing. So adequate is the key. And that's a definite unique to each person. But it's certainly something more to think about for the person. Some assistive techniques. Valsalva does help. Some people find it very good. In order to create a Valsalva, doing push-ups, like arm push-ups, not real push-ups. Some assisted devices. This one here, I believe, is a suppository inserter, and this, I believe, is a digital stem stick. The reason I know that is this one has a little spring up here, because you put it in there, and then when you put it in, it kind of springs the suppository in a little bit. And this one is purely artificial finger, if you will. It's cleanable, etc. But that works. Dig-stick, suppository inserter, mechanical lift. So some people actually use their Hoyer lift and make sure it's a split leg sling and that sort of thing. When they do that, that gets a lot of pressure in that abdominal area. That creates a Valsalva artificially. So many people can use that as a help in their bowel program, and they'll actually do their bowel program in the lift. And this is, again, for a higher quad that they're trying to think about doing that. It works pretty well for some people. Transfer boards, obviously, to get on off the commode, etc. Rolling shower commode chair or shower commode benches. This is a relatively simple one. There's also the tilt and space ones that, again, if you're a high quad, may be essential to keep you in position and get you in an more upright position. Tilt it back a little so you're not as unstable and rolling. They may even need side supports on it for them. All right, this is the medication section. So watch what you're giving people. That's one of the things. What am I doing to screw them up? That's one of the things I think about pretty much every day, because I look at something going wrong and I was like, what am I making happen that shouldn't be happening? Because I always blame me. And it's usually right. So hypertensive meds, cardizem, Lasix, Norvasc, Procardia, they all they help your hypertension, but they do constipate you to some degree. The biggest one, though, pain meds, narcotics, less so the non-steroidals, but they can slow you down a little. Narcotics are notorious, though. In fact, there's 3 or 4 now, I guess, specifically for opioid-induced constipation, and that's purely to fight the side effect of pain medicines. Antidepressants, Elavil is a big one. It also stops your voiding. So got to watch that. These are the anticholinergic elements in those. So compassionate, conservative, constipation, narcotics. That's my favorite one. By the way, that was the just say no guy, so that's why I put him in there. Anyway, all right. Other things that that constipate you, ditropan. So these are again antispasmodics for bladders, and they're all anticholinergic. So that's why. Sedatives, Benadryl, Compazine, Haldol, which we don't use, but if you had it, that would constipate you. Some supplements. Iron tends to bind many people, and then Tums, the calcium carbonate, definitely can slow you down as well to some degree. What do we use to make it go faster? So stool softeners, and we talk about not making it gooey, but it basically facilitates the mixture of stool and fat and water so it becomes slippery. I call them lubricants, okay? And I have my favorite thing is I'm trying to create a log, I'm trying to grease the log, and then I want to push the log on down for the log flume ride, okay? This is the grease for the log. This is keeping it slippery. Colace does do that theoretically. Now, there's no good studies so they've taken it off the formulary in our hospital, except for spinal cord injury, because it's actually recommended by the consortium, and we're pretty confident that it works, but we don't have any controlled randomized trials that say so. But it's also pretty harmless, and if it keeps it sliding better, I'm going to keep giving it to people. You can do mineral oil, but I think you can also overdo mineral oil, and I think there's some stuff with it maybe interfering with some absorption of some different vitamins and things along the way. Bottom line is it's usually a lot more messy and tastes worse, and Colace is a little red jelly bean that nobody minds, and it seems to bring in that stool fat and help it slide better. Stimulants, all right. It actually increased peristalsis. It also alters the fluid and electrolyte transport, and it helps fluid come into the bowel. All right, what's the biggest one? Well, Ducalax is a big one. Ducalax tabs. It used to be back in the day we'd use a lot of these. You'd see guys taking 4 Ducalax tabs, literally 4 of them, which I think you're only supposed to take 1. I've seen up to 6, I think, at one time, which was his normal bowel program to get him to go. And it would increase that peristalsis and stimulate things to work. We don't use that as much as we might have at one point, but it's still an option out there. One of the side effects of that one was cramping, colonic cramping, because it actually did make it peristalse more, and sometimes that became uncomfortable. It could conceivably cause autonomic dysreflexia, but I can't say that it did. Cascara is off the market. That's another one. You may be able to find it in a health food store as one of those natural, laxative kind of thing, natural stimulants. You may be able to find that. Senecot, one of my least favorite things, because it does stimulate and it works really well, but it stimulates with by increasing that peristalsis, but it also alters the stool consistency. You can also find Senecot non-processed as a tea. It's called Sena tea, Smooth Move tea. I think there's a few others. There's some other at the health food store you can find. You brew a nice tea of that, it will help you become more consistent in your production if you needed it. Castor oil is another one that was old school. You don't see it much, but it's out there. So the other ones that I like are the osmotic laxatives. They're usually non-absorbed sugars. They go down to low molecular weight organic acid, and that actually draws fluid osmotically into the lumen, and that does somewhat help to increase stool bulk, but I tend to use those significantly, especially lactulose for a blowout and that sort of thing. Be careful with sorbitol, because that's the one that's in those sugar-free candies, and you eat a bag of sugar-free candies, you're going to have problems, and that's what people do Sometimes I've had, diabetics especially get those brought in. Oh, they're so good. I only had 30 of them. That's what's going on. So watch. Miralax is my favorite one because it's pretty mellow. It doesn't make you go, but it helps you go, and it pushes purely. It doesn't absorb. It does not absorb, it does not alter the stool consistency as much. Mag citrate's another one. It's more of a cathartic and only used infrequently. So that's pretty much it. Okay, fiber, bulk forming laxatives. They call them laxatives. I consider the ones that have like benefiber. That doesn't. It's a bulk former, but not as much a laxative. The Metamucils, the psyllium containing ones, are laxatives. They add bulk, but they also push. That's one of the reasons I don't like using them. Plus, if you've ever used Metamucil, it turns into snot and tastes like hell. Even if the flavored ones, they don't taste good, and they really get jelly. It's gross. So I just don't use it at all. So some things that happen: hemorrhoids, about 3/4. Abdominal distension, yeah, that's pretty common. When you're having a problem, you're going to see it. Dysreflexic, almost 43% of the people that were at risk for it would have it occasionally with bowels. Difficult to evacuation at all, it's about 20%. And then prevalence increases with time. So as you get older, it's going to get worse. That's kind of like most of us. As we get older, some of those things start to slow down and not work quite as well. And you have to modify what you're doing. So 60% of tetraplegic patients require assistance, which about 16% of paraplegics. So that kind of shows this is much more in that social history you took. It's really important to figure out who's going to be filling that help area. And then over 30 years in the injury, you're going to have a higher expecting incident of colorectal cancer, which is interesting. Used to be we didn't even consider that, but I still am trying to figure out what a good bowel prep is for a spinal cord injured patient. I've even asked some guys that I knew that were quite experienced, and they couldn't tell me what their recommendation was, because they said, well, just give it a try, see what happens. But there's no guidance out there that this works best. Reflux is a common one. Hemorrhoids, exacerbated by stuff like suppositories, enemas, dig stem. You treat it when it's clinically significant. Pain is possible. Bleeding is clear, and then they may prolapse, so it becomes a real problem. And oftentimes, if they're having them, that'll be inducing of autonomic dysreflexia, because they hurt. If you've had them, they hurt, and it can cause that, stimulate that. So what do? Stool softeners, get them soft, get them to flow out, not hard rocks they're passing, and then use topical anti-inflammatories and or hemorrhoidectomies. So this is an ostomy, obviously. The key here is colostomy versus ileostomy. You want to go as low as you can so you have a more manageable option. Ileostomies tend to be very high volume and loose and much harder to deal with. So when do you go to this? This is not a failure. It's another alternative, okay? I want to make sure that everybody understands that. I used to think this was we screwed up and couldn't fix it. And I'm like, well, yeah, sometimes that's true. But make sure it's not true. Do your best you can to get it to work without it. But then again, there's sometimes the right tool for the right job. So some people are dissatisfied with their bowel care time. It takes me 2 hours to get it done. I've tried everything in the world, etc. I can't go out because I'm worried I'm going to poop myself, and I can't get over that. Well, the social activities restriction is not good. Sweating, anorexia, nausea. I'm just, can't eat. I'm nauseated all the time. Fatigue and abdominal pain, leakage of fecal matter. I just can't keep it in. It no matter what I do, no matter how I eat, etc. Bowel chair trauma. That's basically decubitus caused by bowel care, and sometimes you'll need to divert the stream for decubitus healing so it doesn't soil the tissue as they're getting fixed. And then hemorrhoidal bleeding, if it's that severe, that would be pretty impressive. I do know one lady was dissatisfied by her bowel care time. It was also, for her, extremely disconcerting that her husband had to help her with it. And about a year after she had the injury, this was a long time ago, she convinced me that we needed to talk to a surgeon. We sent her to the surgeon. He performed an ostomy, and she was about as happy as anyone ever had been, because it just gave her more dignity. So, and she could manage it herself, which was really good for her. So it's not always a medical reason to, but it's not something to enter in lightly, because there are side effects there too. All right, bowel program, effective, eliminating and reduce GI evacuation complaints. Intervention requires awareness of the preferences, their functional status, and social and emotional supports. All aspects of the bowel are designed to be easily replicated in an individual's home. So that's when you're designing one in the hospital, it should be replicated in the individual's home. You need to have something they can take home and use. And then you need to know the clinical presentations and diagnosis of the common complaints so that you can respond to them and try to avoid them.